The root of the sixth cranial nerve is long and tortuous. The starting point is a nucleus in the caudal pons. Axons travel ventrally to exit at the pontomedullary junction. Then the nerve turns rostrally in the subarachnoid space to proceed along the clivus. When it reaches the top of the clivus, it abruptly turns almost 90 degrees to pass through Dorello's canal to enter the cavernous sinus. In the cavernous sinus, the sixth nerve lies just inferolateral to the carotid artery. It exits the cavernous sinus in the superior orbital fissure to enter the orbit and supply just one extraocular muscle, the lateral rectus. Start with the sixth nerve nucleus in the pons. Here is another view of that nucleus in a slice of the pons. It actually has two populations of axons. One population consists of interneurons that travel rostrally in the MLF to link with the contralateral third nerve nucleus and eventually the medial rectus muscle. The other population consists of fascicular axons that eventually reach the ipsilateral lateral rectus muscle. Now follow the fascicular axons as they travel ventrally through the tegmental and basis pontus. On their way, they cross pontocerebellar and corticospinal pathways. They exit the brainstem as a compact single nerve that bends to ascend along the clivus and disappear under the petroclinoid ligament in the narrow space of Dorello's canal, where the nerve enters the cavernous sinus. In the cavernous sinus, the sixth nerve is the only oculomotor nerve that does not lie in the outer sinus wall. Instead, it lies in the middle of the venous lake, inferolateral to the carotid artery. The nerve then enters the orbit through the superior orbital fissure to supply the lateral rectus muscle. Go back to the sixth nerve nucleus. It lies near the midline, just ventral to the floor of the fourth ventricle at the junction of the pons and medulla. It receives input from the pontine paramedian reticular formation to generate saccades, from the dorsolateral pontine nuclei to generate pursuit, and from the vestibular nuclei to generate vestibulo-ocular movements. When the sixth nerve nucleus is stimulated, interneurons and fascicular axons are activated so that the eyes move conjugately to the same side. What kinds of lesions damage this pathway? First, there are congenital sixth nerve nuclear lesions. They typically spare the internuclear axons so that a gaze palsy does not occur. Instead, patients usually have an ipsilateral abduction deficit and usually esotropia in primary gaze position. You may also see retraction of the affected eye and narrowing of the palpebral fissure height on adduction, a condition called Duane syndrome type 1. This patient has absent abduction in the right eye. When she looks to her left, the vertical height of the palpebral fissure narrows. This alteration in palpebral fissure height, when combined with an abduction deficit, is characteristic of Duane syndrome type 1, a congenital dysplasia of the sixth nerve nucleus. You may encounter an adduction deficit in Duane syndrome type 2, or you may find a combination of these abnormalities, an abduction and an adduction deficit, as part of Duane syndrome type 3, as shown here in reduced form in the left eye. This patient reports intermittent diplopia when she looks far to her right or left. When she looks from side to side, the left eye does not fully adduct or abduct. Also, notice that the left palpebral fissure height narrows when she looks to her right. In straight-ahead gaze, she has an exodeviation that increases on right gaze. In left gaze, she actually has an esodeviation. If you add the changing palpebral fissure height to the slight adduction and abduction deficits and the changing alignment pattern, you arrive at a diagnosis of type 3 Duane retraction syndrome, a congenital disinnervation resulting from dysplasia of the sixth nerve nucleus and miswiring of the medial and lateral rectus muscles. Acquired lesions of the sixth nerve nucleus differ from congenital lesions in that they typically damage fascicles destined for the lateral rectus and interneurons traveling in the MLF destined to innervate the contralateral medial rectus. Therefore, acquired lesions of the sixth nerve nucleus create an ipsilateral gaze palsy for saccades, pursuit, and vestibulo-ocular movements. In this lesion of the right sixth nerve nucleus, the eyes will move normally to the left, but they will not move to the right under any stimulus. Look as far to your right as you can, but don't move your head. Look all the way to your right. Now look all the way to your left. Now back all the way to the right. Way fast to the left. Now back to the right as fast as you can go. But here's the point. Acquired lesions that damage the nucleus also damage adjacent structures. For example, seventh nerve axons looping over the sixth cranial nerve nucleus are often in harm's way, so expect to see a lower motor neuron facial palsy as you see here. This patient has a left pontine cavernoma that has caused a left sixth nerve palsy, a left gaze palsy with substituted convergence, and a left seventh nerve palsy. The fascicular segment heads ventrally on its way to a pontomedullary exit. Damage here leads to an ipsilateral abduction deficit, but because the fascicles cross such heavy pontine traffic, there will be other neurologic abnormalities such as nystagmus, saccadic pursuit, skew deviation, ataxia, or contralateral hemiparesis. The subarachnoid segment of the sixth cranial nerve travels rostrally along the clivus. In this subarachnoid segment, the most common non-traumatic cause is ischemia to the nerve. Meningeal spread of cancer and infectious meningitis also work on the sixth nerve in this segment. The palsy will appear as an isolated ipsilateral abduction deficit that may be partial or complete. It looks exactly like a fascicular sixth nerve palsy, but here's the difference. There will be no nystagmus, skew deviation, or ataxia because the lesion lies outside the brainstem. As there is less neurologic traffic outside the brainstem, the ocular abnormalities that you see here may be all that you find. The subarachnoid segment is also the site of sixth nerve palsy from head trauma, especially when there is bleeding under the clival dura. In head trauma that damages the sixth nerve, fractures and dislocations of the first and second cervical vertebrae are common. If the patient's head is not immobilized and the neck is not surgically secured, the patient may end up paralyzed from the neck down. The sixth nerve enters Dorello's canal on its way to the cavernous sinus. Here the nerve is wedged between the clivus medially and the petrous apex laterally. Cancerous or infectious lesions of the clivus or sphenoid sinus are common causes of sixth nerve palsies here. Middle ear infections that spread through the petrous bone to its apex may inflame the overlying dura and damage the sixth nerve as it passes through the narrow confines of Dorello's canal. Because the nearby trigeminal nerve is also affected, the sixth nerve palsy here is particularly painful, a condition called Gradenigo syndrome. This little boy developed a middle ear infection on the left that spread to his mastoid and petrous apex. When he looks straight ahead at the camera, you see that the corneal reflection is displaced laterally in the left eye, so he has esotropia. When he looks to his left, the left eye floats in incomplete abduction. When he looks to the right, the eyes are aligned. This is a left sixth nerve palsy in the setting of petrous apicitis, a condition known as Gradinego syndrome. Another important cause of sixth nerve palsy probably also occurs at this location. High intracranial pressure created by obstructive hydrocephalus, dural sinus thrombosis, or a cerebral mass pushes the brainstem downward and tugs on the sixth nerve where it is tethered at its entry to Dorello's canal. The same stretching phenomenon may cause sixth nerve palsy and intracranial hypotension. In that case, low pressure caused by a cerebrospinal leak also causes the brain to sink, pulling the sixth nerve as it slips downward. In these circumstances, sixth nerve palsy may be the only or most obvious manifestation. Intracranial hypotension may arise after lumbar puncture or after epidural anesthesia that inadvertently punctures the dura. Because intracranial hypertension and hypotension arise from lesions remote from the sixth cranial nerve, this form of sixth nerve palsy is often called false localizing. In the cavernous sinus, the sixth nerve is unique among the oculomotor nerves in lying within the sinus rather than in its outer wall. The nerve travels inferior-laterally and very close to the intracavernous carotid artery, so this segment is vulnerable to expanding intracavernous aneurysms. The oculosympathetic plexus hugs the outer wall of the intracavernous carotid artery, so lesions affecting the carotid artery often produce a Horner syndrome. The sixth nerve enters the orbit in the superior orbital fissure. It immediately penetrates the medial belly of the lateral rectus muscle. Sixth nerve palsies do not occur from lesions in the orbit. When an orbital lesion limits abduction, blame it on obstructed movement of the eye, a damaged lateral rectus muscle, or scarring and restriction of the medial rectus muscle, as occurs often in Graves' disease. Here are some guidelines for evaluating non-traumatic sixth nerve palsy in adults. Suppose the palsy is the only neuroophthalmic abnormality and the patient has no history of cancer. Then you can presume that it is an isolated sixth nerve palsy. If the patient has appropriate ischemic risk factors, you can safely blame it on extraaxial ischemia and defer diagnostic studies to allow spontaneous recovery within 3 months. If recovery does not occur within that time or some other pertinent abnormality develops during that interval, you must initiate brain imaging or other appropriate studies. If, on the other hand, the palsy is accompanied by other pertinent abnormalities at the outset, or there are other odd features, then you must call it a non-isolated sixth nerve palsy and promptly initiate brain imaging and other appropriate studies directed at meningeal and brain parenchymal causes. Recall that sixth nerve palsy can be caused by increased or decreased intracranial pressure. Be sure to rule out papilledema as a sign of increased intracranial pressure, which may be a cause of a false localizing sixth nerve palsy. And remember that myasthenia gravis can mimic a sixth nerve palsy. Also remember that these guidelines apply only to adults. In children, even isolated sixth nerve palsy must be fully evaluated, including brain imaging. Here is another way to guide you in the management of non-traumatic sixth nerve palsy with a flowchart. If it looks like a sixth nerve palsy, be sure that it is not an abduction deficit of another cause. Consider these possibilities. First, think of myasthenia gravis. It can produce any type of ocular misalignment, including an abduction deficit. Remember that acetylcholine receptor binding antibody is not always positive unless the myasthenia is generalized. So if that test is negative, you might need to order a more sensitive test, such as single-fiber electromyography, or resort to a therapeutic trial of pyridostigmine or corticosteroid. An orbitopathy that consists of a mass or swelling and scarring of the extraocular muscles can look like a sixth nerve palsy. The medial rectus muscle is a favored target in Graves' disease, so when it enlarges and tightens, it may restrict abduction. Do not expect always to find orbital congestive features, but you should look for lid retraction and lag, resistance to retropulsion, and orbital imaging signs of inflammation or mass. Spasm of the near reflex is a psychogenic disorder in which convergence interrupts horizontal versions. It can look like an abduction deficit. Look for intermittent esotropia timed with meiosis. A clue is that the abducting eye lags. A large esotropia will be evident on cover testing. If you have excluded imitators and settled on a real sixth nerve palsy, you must determine if the sixth nerve palsy is isolated, the only pertinent abnormality on examination, or non-isolated, one of many pertinent abnormalities on examination. If the palsy is isolated, decide if it can be safely attributed to reversible ischemia of the extraaxial segment of the nerve, the most common cause in adults. Ischemia usually occurs in patients who have the classic arteriosclerotic risk profile, a personal or family history of diabetes, systemic hypertension, dyslipidemia, obesity, or heavy smoking. With that profile, you could defer investigative studies, including brain imaging, to allow spontaneous recovery within 3 months. Without that profile, you would have to hesitate in attributing the palsy to extraaxial ischemia and consider prompt imaging and additional studies. There are many other reasons why you would not want to assign a diagnosis of ischemia. For example, children and young adults are not entitled to that diagnosis and would have to be worked up. So would those with a history of cancer or findings suggestive of high or low intracranial pressure. If there are neuroophthalmic features on examination to suggest that the sixth nerve palsy is not isolated, you must promptly engage in a workup to rule out tumors and inflammatory causes. On the other hand, features of a congenital sixth nerve palsy, known as Duane syndrome, would be a reason to avoid an unnecessary workup.